Welcome to our Permanente Live webinar, The Future of Equitable Care. I'm Stephen Parodi, Executive Vice President with the Permanente Federation and Associate Executive Director with the Permanente Medical Group, and I'll be serving as your moderator for today. We are living through unprecedented times, and I want to extend my appreciation to all of you in healthcare who are taking time out of what is an extremely busy day to join us for this important conversation. Racial and ethnic health disparities have existed in America for a very long time, but during the pandemic, it's become a national conversation. And that is why we're all here today. Before I introduce our speakers, I want to remind everyone that this session is being recorded and can be streamed later. We'll also have a Q&A session at the end, and you're invited to submit your questions during and using the Q&A function on Zoom. So let's go ahead and get started. I am so pleased to have joining me, albeit virtually, this esteemed group of physician leaders from across the country. First, we have Dr. Nkem Chukwumerije, President and Executive Medical Director of the Southeast Permanente Medical Group, which provides care to more than 200,000 Kaiser Permanente members in Georgia. Dr. Nancy Jin is the Executive Vice President of Quality and the Chief Quality Officer with the Permanente Federation, which supports the 8 Permanente medical groups representing more than 23,000 physicians. Dr. Kedar Mate is President and CEO of the Institute for Healthcare Improvement. And lastly, Dr. Karthik Sivashanker is Vice President of Equitable Health Systems and Innovation at the American Medical Association. Thank you all for joining me today. So I want to go ahead and start with you, Karthik, with the first question. And as mentioned at the beginning here, the issues of health disparities is not a new problem. And during the pandemic, we've seen a disproportionate share of COVID illnesses and deaths among Black, Latinx, and other communities of color. The AMA has made health equity a priority, and that's work that you're helping to lead. So could you talk to us a little bit about some of the major issues that the pandemic has revealed about health equity?
Yeah, happy to be here, and a great question. So a good place to start is really just with the data. So we've seen from early on in the pandemic that COVID-19 has been differentially impacting populations, with Black, Latinx, Indigenous, other populations being more severely impacted. And for some, that was a surprise, but it really shouldn't have been a surprise. And I'll talk a bit about that. But there's also this myth out there that some of these communities weren't taking it seriously. And there's lots of data to say that that's not true. So there was Pew Research data from early in the pandemic, essentially showing that Black, Latinx, lower income folks were actually more worried about getting COVID-19 and needing hospitalization and spreading it to others. They were also more likely to buy non-perishables. So it's not a problem of them not taking it seriously. So then why are we seeing these differential impacts? And really, it shouldn't be surprising when we look at the history of our country. So most of our history has been in a time of slavery or Jim Crow segregation. And only in the last 50 something out of the last 400 years do we not have that state, but we have the war on drugs and mass incarceration and felony disenfranchisement. So there are these structural issues leading to differential impacts, and we can break that down further. So in healthcare, we have this history of unethical medical experimentation, which has manifested as medical distrust. And so with COVID-19, we see this lack of trust in hospitals or providers from some historically oppressed populations. And that came out in very visible ways around goals of care and visitor policies and who has access to ventilators or not. With criminal justice, we have the school to prison pipeline. So if you're Black in this country, you're 20% more likely to get sentenced for the same crime, and about as the same in terms of being more likely to spend time in jail for the same crime. And so we see this huge difference in terms of 1 in 106 Black men incarcerated versus 1 in 15 white men. So once again, we see that they're confined more often in unsanitary conditions, lack of ICU care, leading to differential infection rates and mortality. When you talk about economic discrimination and other inequities leading to that huge wealth gap between populations, that manifested with COVID-19 in terms of essential low-wage jobs being at risk, hired last, fired first. Even having resources to quarantine is a privilege. So we see these differential infection rates. And when you think about housing, so housing discrimination and the huge homeownership gap, even having space to isolate or access to public transportation, or needing to take public transportation instead of driving, these are all privileges that we take for granted, leading to differential infection rates. And with the pandemic impacting our staff, for example, we saw that our lower wage frontline workers were getting COVID at up to 10 times the rate. When we looked at the causes for that and did contact tracing, it seemed to be reflecting community level transmission. So this reflects in itself historical redlining. So it's not accidental that certain communities are getting hit harder. So COVID-19 was really just a magnifying glass for inequities that have been there all the time. And none of this should have been surprising, and all of it could have been anticipated, which really begs the question, how do we do this differently in the future? How do we plan for the next disaster and plan for inequities that are going to emerge? I'll pause there.
Thank you, Karthik. And Kedar, what comes to mind here is that IHI has made equity one of the core values of the organization. And actually, which is quite timely here, the IHI just released this week a report based on a health equity poll. Could you share with us some of the key learnings from that report?
Yeah, Stephen, thank you for the opportunity to be here, and really appreciate being part of this panel with my esteemed colleagues, and also glad to be part of a conversation with our strategic partners at Kaiser Permanente. So it's really wonderful to be part of this discussion. As you mentioned, IHI just has committed itself to equity. It's one of our 4 organizational values, which we apply as much internally in the organization as externally, as we try to create a relationship between quality and equity in the wider health ecosystem in the world. There has been as many of you know, I think, and the poll shows that you just described, a very significant shift within healthcare delivery organizations and within healthcare in the health ecosystem around prioritization of health equity. In the past 2 years, since the last time we did a survey like this of healthcare leaders around the country, there's been a dramatic upshift in prioritization around health equity. The poll that we just did found a 33% increase in the number of healthcare leaders. This was across over 500 healthcare leaders that responded to this survey. A 33% increase in the number of those leaders that identified health equity as one of their organization's top 3 priorities for their organization. This is very different to what we found just 2 years ago, when a very small percentage of people identified equity as being a very significant priority for the organization. It's now second only to patient safety among the top priorities for quality in healthcare leaders. So this is a very big change for us. Patient safety has dominated the quality landscape for a long time. And now equity is right there with it. And again, equity was the biggest jump compared to all other aspects of quality in healthcare. So it's a big change for us. There's clear acceptance, I think, of the fact that there is, or there can be no progress on healthcare quality without a progress on health equity as well. But at the same time, the poll shows that healthcare leaders across the industry are facing a number of challenges around how to advance equity in their organization, specifically around staffing concerns, around skills related to how to improve equity, data systems, which we'll come back to, I'm sure, at some point in this conversation, and support internally for funding to make all of this work. There are some specific ideas that the poll revealed around what delivery systems can do and what clinicians can do to start working on health equity. And just to summarize them very briefly here, some of those ideas included collecting and stratifying data by race, ethnicity, language, as well as investing in quality departments and population health departments to use their teams and tools to address inequities in their delivery organizations today. Lots of useful guidance around how to find specific clinical areas where inequities are present and prevalent, and starting to take action to try to remediate those equities together by listening to affected communities first, and then taking actions to co-produce better outcomes with our communities. And also some very specific and I think really useful ideas. There's been a lot of attendant interest in social determinants of health and social needs care, and some of what Karthik just mentioned around some of the other determinants that have caused some of the health inequities that we're seeing. But one of the useful things that I think we've observed in the poll and in IHI's work on pursuing equity, the initiative that we ran that Kaiser actually participates in and has participated in for many years, But in that work, we've learned that when organizations pick areas where there are significant inequities present in the clinical context, they then chose social needs and social determinants that influence those clinical outcomes. And when you do that, when you pick a combination of a clinical goal to reduce inequities around and the social determinants or social needs that inform that clinical goal, you make progress on both even faster. So I'll pause there and turn it back to you, Steve. But lots of really good and rich information in this poll around what delivery systems can do. There's also information about what payers and regulators can do. We can come back to that perhaps at a later time in the conversation.
Yeah, thank you, Kedar. There's a lot to chew on there. So I know we're going to come back to you here. So Nancy, now you and I talk fairly frequently. You are the numbers person when it comes to amongst the two of us, when it comes to quality and measurement. And can you talk a little bit about, we're a large organization, KP, and what we're doing to address health equity, and describe some of the steps that we're taking in terms of that with the lens of improving quality and focusing on equitable care.
So thank you so much, Steve. And it really is an honor and a privilege to be with this esteemed group today. It has to start with a willingness for self-reflection for organizations to identify the extent of the issue and then a clear commitment to change and improve. So that commitment is in our DNA at Kaiser Permanente. We have maintained a deep and enduring focus on health equity long before the pandemic and national awareness really began last summer. A focus that has reduced and even in some cases eliminated health disparities among racial and ethnic groups. So for instance, hypertension control for Black and African American Kaiser Permanente members is 60% better than the national average. We also have colon cancer screening rates for our Latinx members that has improved 21% since 2009. And we rank in the top 5% in the country for cervical cancer screening and eliminated meaningful disparities in cervical cancer rates for the diverse populations that we serve. So yes, we are moving the needle, but we know we still can do better yet. So we have made a foundational commitment to drive equitable outcomes for patients and communities. It's an important component of our organizational goals. So we have already have in place extensive population health systems infrastructure and have just started to work on incorporating race and ethnicity and segmentation into that quality performance reporting on a systematic basis. So the goal is to develop that systematic approach to identify, track, and close care gaps. And we are starting by focusing on 3 key clinical areas: mental health and wellness, cancer care, and cardiovascular health. So in much the way that Kedar looked at the merging of quality initiatives, layering in equity is really going to move that needle.
Yeah, thank you, Nancy. Nkem, as we talked about earlier, the pandemic really has shined a light on health inequities, and again, to previous points, they were already there. It's just that now they're front and center. And it's presented us also opportunities to tackle these issues. And vaccine distribution is an example of that. And I know KP's developed a playbook to help organizations, as well as our own, to roll out vaccines in an equitable fashion. And how did you approach vaccine access in such a diverse area as Georgia?
Yeah, no, thanks, Stephen, and thanks to all the panelists. No, this is a very good question. So just to give you a context about our environment in Georgia, we have about, in the metro Atlanta area, which is really where KP is, we have about 6 million people, and it's very diverse, both by racial, socioeconomic diversity in the entire area. And we serve actually about 315,000 members in that diverse area. So just to give you a context too, self-identification of our membership, about 42% identify as Black African Americans. and about 30% as white. Those are the two highest populations that we serve. Most of our African-American community live in the south part of the city, just to help you understand. And we've known over the years that they have most of the burden of the chronic conditions. So we've had the long-standing efforts, just like Dr. Nancy Jean said in KP, of concentrating our population health efforts around diabetes, hypertension, obesity, especially in this area. So we're already doing things around health equity in that area. But just like you said, during when it was time for vaccination, we really had some 3 guiding principles earlier on. One of them is really making sure that we are leading with equity, ethics, and fairness in our process. The second principle was just to make sure that we were focusing on the most vulnerable population who had the chronic illnesses. And the third principle for us was equal access. Equal access to us would mean making sure that when we made the vaccine available for people to make appointments, that we took into consideration folks who wouldn't know how to go to kp.org, which is our virtual way of making the appointment. So we had phone access to them, and we sent postcards, etc., and an outreach program to make sure that we had equal access. So that was one of our 3 guiding principles we used. In addition to that, we had the Healthcare Disparity Advisory Committee that we get input from, especially about some of the observations around the impact and concerns of vaccinations among especially the African Americans and Latinx communities in our area. So we get input from them to kind of get the member voice, about how to go about the vaccine distribution. And thirdly, we actually conducted a research that we published in the British Medical Journal. We also, looking into to understand the clinical behavior and social factors associated with racial disparities in COVID-19 patients. So we've kind of using our guiding principles, our advisory committee input and research to kind of inform the way we distributed our vaccination. So about 35% of our membership live in the south part of Atlanta, like we said, but the disease burden is more there. So our distribution, actually, we distributed about 50% of our vaccinations to that geographic area for 2 reasons. 1, because of the disproportionate disease burden, but 2, to make sure that we were not serving only our members, but non-members. So we had to also serve the communities that we serve, not just the KP members. So that was very, very important to us. And we also considered geographic access to care when we started expanding our sites for vaccination. So we went to the Panola area, which is another area that is towards the east side. That was also predominantly folks that were more vulnerable. In addition to this, another thing we did was make sure that we had a core group of our providers or physicians who were doing both internal and external efforts, to make sure that increased vaccination rates, and engaging our business groups, like African American communities, to make sure, and the Latinx groups, different business resource groups, to make sure they were engaged in the community. So we had almost about 100 events, that our providers participated in the Metro Atlanta area, trying to make sure that we're encouraging vaccination. And internally, we still continue to do that. We call it Real Talk. So tomorrow, for example, we have a Real Talk about how to get both COVID-19 vaccination with flu vaccination. So 6 of our providers will be giving internal talk on how to do that. So the outcomes wise, it shows that we have about 58% of our membership that are, that are eligible for the vaccination now vaccinated, which is above the Georgia average. But even more encouraging about the disparity in African American vaccination rates compared to whites for COVID-19 vaccines is about 5% for us, which is much less than we have for flu vaccination. So it seems like the efforts worked a little bit, and we are very glad about that. And then we continue to look at the data, just like you said, and we stratify our data to understand the impact, not on just race, ethnicity, language, etc. And that continues to inform the way we continue to distribute and implement our vaccination programs. Very glad that it's been a very challenging situation for us in Georgia, like most of you know. There is the medical distrust, like Karthik mentioned, is very prevalent here. So one of our goals is how do we become trusted healthcare partners with the communities that we serve?
Yeah, thank you, Nkem. All of you actually touched on, taking a data-driven approach to this. And Nkem, your remarks also, factor in this human factor. And there were two things that really stood out to me. You talked about listening and then also dialoguing and speaking about it. So touching on that and sort of going broader, and this question is really going to be for all of the panelists, is looking to the future. Now that we're a year and a half into this pandemic, and we're only going to see ongoing need here to address these issues. And what I liked about all of your comments is that this is not just about the pandemic. This is really about how we provide healthcare writ large. Karthik, if I could start with you, where do you see the AMA going in the future with this? And what are going to be the priorities in the coming, say, year or two?
So we just released our strategic plan. It was 2 years in the making under the leadership of Dr. Aletha Maybank. It's a very ambitious and bold vision, I think, for organized medicine. And I would encourage anyone to take a look at it. It's on the website. It's a long document, it's 60+ pages, but it's absolutely worth the read because it really provides some of the foundation, the context, the why, and then points to 5 kind of pillars of work that we're going to be focused on. So embedding equity in practice, process, action, innovation, organizational performance and outcomes, building alliances and sharing power by meaningful engagement, ensuring equity and innovation for marginalized and minoritized people and communities, pushing upstream to address all determinants of health and addressing root causes, and fostering truth, reconciliation, racial healing, and transformation. And my work is really focused in the pushing upstream or the equitable health system strategy. So we're thinking about it at kind of multiple levels. The first being public health and cross-sector engagement. So up to now, we've been very fragmented in our approaches and very siloed, but we really need to do more to coordinate across sectors. And we're doing some of that work with IHI as well to partner. So how do we coordinate across sectors, including public health, social care, healthcare, and beyond, to promote people, community-centered collective action that really addresses and dismantles those intersecting systems of oppression. And that's getting at big questions like, how do we shift from this sort of service-oriented social welfare program and downstream healthcare delivery approach to more meaningful reform that addresses those root causes that are ultimately driving the inequitable outcomes that we're seeing? In terms of healthcare institutions, the focus is really on eliminating harmful variation in healthcare delivery, access, and outcomes. And to Kedar's point, how do we embed equity in the DNA of hospital operations, quality, safety, data, education, and really promoting place-based, equity-focused anchor mission approaches that center community and historically marginalized voices. And so what do I mean by that? An example would be, how do we start talking about this in a totally different way? So shifting from Band-Aid approaches like food assistance for employees or patients to more meaningful organizational changes like thriving wages for employees, to even more broader organizing and advocacy like supporting thriving wages for all workers and workers' rights. And then thinking about things like leadership and organizational structures and how does that maintain privilege and power in all aspects: strategy, governance, advocacy, finances. And then for providers, how do we develop a pipeline of providers who are actually equipped with the racial structural justice praxis, who are capable of redesigning, reimagining healthcare as more than just delivering services, but actually improving health? And so there's a lot of work and a lot of programs that we're launching just within this one pillar, but across the center, and really with a lot of partners. This is work that no one institution or organization is going to solve for on its own. It's work that we all have to do together.
Thanks, Karthik. Let me turn it over to Kedar.
Yeah, thanks. This is a great question about how to think about the future. I think I would say a few things. One is we found that organizations, and I'm so pleased to say that I know KP has made health equity a strategic priority for you, and Nancy, you talked about it, and I think we've seen that all the way through. We've been partnered with KP in our Pursuing Equity work, which is really foundational for what IHI is doing in this space. So organizations that make equity a strategic priority for themselves and then back that strategic priority up by real investment in data assets and informatics to help understand the scope of the challenge and problem, that supply that data to their clinicians in a non-judgmental fashion. I think all of that is how we actually, is what we, when organizations make those kinds of investments and make equity into a strategic priority and back that priority up with investments like that, that's when we see real movement in these areas. We've done enough, framework development and enough understanding of admiring the problem for many years, I think, and the time now is for real action. And what I think motivates organizations to move towards action is when you see that kind of real investment in strategic relationships and priorities to make things happen. One of the things I'll say in addition to that is, mechanistically within healthcare delivery organizations, you've got to find some place in the system where there is a set of skills and a team that's ready to pick this up. And I think what Nancy, you're doing with the quality of systems within KP is exactly the right way to go. It's exactly what we saw in our Pursuing Equity initiatives across 30 healthcare delivery organizations. Those that prioritized equity, invested in data capacity, and assigned that responsibility and accountability for improving or closing gaps in performance to the quality team or the population management team. That's where you saw progress in all this. And then lastly, I'll say that the connection to community and social care organizations, the creation of more equitable care is not going to be in the province of healthcare delivery alone. I think all of us can recognize that and understand why that would be the case. But meaningful connection to community has eluded healthcare delivery for many, many years, decades. And now is our opportunity to, I think, invest differently in how we work with communities. And some of what you were describing, Karthik, with anchor activities and really investing in our communities in fundamentally different ways, I think actually testifies to how we can actually make the kind of change that we need. Last thing I'll say, and perhaps one of the most controversial things I'll say, is that I think we need to actually, to really get real accountability around equity going, again, organizations that do this well and do this right, tie executive compensation to quality performance measures and tie it to closure of equity gaps. So I think that's where ultimately we're going to have to go to see real progress on these issues. And to be honest, I'm seeing more and more delivery systems make those kinds of choices. So it's very encouraging. And likewise, I think we're seeing the payer and regulatory environment create the conditions that will allow us as delivery systems and plans to take these kinds of bold actions going forward. So we've got a supportive macro environment with regulators and payers that are aligning themselves around these concepts as well that'll support us all in the future.
Yeah, thank you. Nancy, your thoughts? Oh, Nancy, you're on mute.
Sorry.
We have to have at least one of those during these.
At least one of those moments. Couldn't agree more with Karthik and Kedar's comments. And in particular, we have looked at really, what I consider three essential elements for this work. And one is to embed equity into performance goals. I think you mentioned that, Kedar. And performance goals, not just for executives, but including all of our frontline teams. It raises the awareness of the need. To also embed into our clinical research initiatives. We in Kaiser Permanente have extensive clinical research activities in all of our regions across the program. And by the inclusion of equity in this research helps us to not just identify where there are opportunities, but also what measures we can take as an organization to help to close the equity gaps. And to include advancements in technology to have equity embedded within those activities as well. This will make the care more accessible and plays a role in addressing the health disparities. So it helps us start to address the systemic health disparities within our healthcare systems nationwide and also in our own home. Two, we do need to incorporate the voice of the diverse individuals, our patients, into the care delivery process by involving them not only in the design of their own care, but also in the broader systems of care. We have in many regions very extensive patient advisory councils who make it their job to be included in issues that arise in care delivery, and they become part of the solution design. And through their lens of, as the end user, often shed incredible perspective into what we should be doing. Clear physician-patient communication increases trust and mutual respect as well, and improving patient engagement and the overall patient experience is just critical. And then finally, we need to foster and continue a learning culture. And Kaiser Permanente is a learning organization, and by embedding equity into that learning process to continually improve on our systems, to orient toward equity, safety, and inclusion and accountability will ultimately drive those kinds of changes throughout the organization. Thanks.
Thank you, Nancy. And Nkem, your thoughts?
Yeah, no, thank you very much. I think, in addition to making health equity and disparity the lens through which we also look at both access to care, the way we deliver care, the workforce, making sure that the workforce looks like the people that are taken care of, as well as how we measure outcomes. In addition to making sure that we are using equity as one of the lenses to look through all that, I think, if we want to just zero in a little bit on the care delivery part, I think Kaiser Permanente, for example, we have this long view approach to healthcare, meaning that when you come to us, we're not treating you for the acute reasons. We are looking at the long view preventative measures. We also have an emphasis on long view that looks at social determinants of health, so that at time zero, we are socializing it with our whole healthcare delivery team. It doesn't matter if you're a specialist primary care. We design processes and design systems that support screening for social determinants of health at all points of care. So as we do preventative screening, we do social determinant screening. So embedding that into our delivery system so that the way we deliver care to people considers both the clinical and social determinants, just like Kedar mentioned. I think that's something that we're trying to embed in our delivery system here. And I think for us in Georgia, we're taking it very seriously. The long view of care model, medical, non-medical meaning emphasis on social determinants. And then another thing that was mentioned that is very important, somebody said meaningful connection to the community. I think this is really, really key for us. The medical distrust, especially in this part of the country, there's a lot of it. But we do have trusted community partners already that exist. For example, the churches may be trusted community partners. So how do we as healthcare partners partner with those already trusted community partners to become trusted healthcare partners? So that's kind of an area we are trying to explore. How do we get our providers more into the community to work with those that are already trusted so that then we can talk about healthcare? So I think those are areas that are, we're going to be exploring further. In addition, like I said, to looking at access to care, the workforce, the delivery system, and the outcomes, making sure we are considering race, ethnicity, language, etc., as we do that.
Yeah, thank you, Nkem. And the questions are coming in, and I'm gonna take a couple of questions and amalgamate them, if you will. So there's a whole other sea change that's occurring right now in terms of the practice of medicine, right? And it has to do with telehealth, telemedicine, and that has a lot of different manifestations, whether it's video, whether it's on the phone, or actually more advanced care into the home in various forms or fashion. And in some cases, this appears to be, potentially providing more access, but there's controversy over this, whether this is actually potentially creating disparity in terms of who has access and what kind of access. So let me turn to you, Nkem, first, because you're an executive medical director. You've got responsibility for the operations of, large organization. How are you thinking about that in terms of tackling that? And how do you, address the potential for disparity and yet, turn it around and actually see it as an improvement in access?
Right. Yeah, I think this is actually very good question. And if you see, I kind of talked a little bit about that when we were considering our vaccination appointments, right? if you made all your appointments available only through kp.org, for example, which is a way to do it virtually, would you be missing some segments of the population that may actually not know how to make those appointments? So what we do is actually we offer both, right? We just make sure that we're not completely going virtual, right? So there's an opportunity to also, do face-to-face visits. So, and we're always going back, and talking to our members to see what their preferences are. But in addition to that, we're actually educating. I'll tell you the number of adoption of kp.org in our Southwood offices is very high because we've actually intentionally engaged some of the community members and some of our healthcare folks to engage our members as they come, they get them, they teach them one-on-one, and the adoption rate has been very high. So we're trying to get them to be more literate, to be able to use those virtual telehealth opportunities, but at the same time, we are making sure that there is opportunity for face-to-face appointments. And we are very cognizant of that when we're making decisions on, how to make appointments and things like that. So we're keeping all options open for them and then trying to get people shifting more to virtual care as much as they want to, right?
In Karthik, like the AMA, these discussions are occurring at the national level with, policymakers, both at the legislative level, executive branch levels. How's the AMA sort of tackling that since this whole big discussion around access, equity, telemedicine is all at the forefront?
Yeah, I'm happy to take a stab at it, and would also love to hear from Kedar and his thoughts as well as Nancy. So we have weighed in on the issue, and I think it's pretty clear that we need to continue to support access and expand access. I think it's a good example of how also there's risks associated. So anytime we launch anything at a national level, there's a real risk of exacerbating inequities. So in making telehealth available, what about folks who don't speak English and we have trouble getting the interpreter with telehealth, or folks who don't have a device? So my patients, a lot of them don't even have a smartphone. And so the AMA has really advocated not just for reimbursing for telehealth, but also phone visits. I think that's absolutely critical. And I think that is going to be something that is going to happen moving forward. But I think we also need to think about who are we missing as we kind of drive some of these solutions. What about our immigrant populations, folks who are here in an undocumented status? How are they going to access any of this? And so as we roll out these national initiatives, just thinking about what are the unintended consequences, and sometimes we can widen the gaps between certain groups, and how do we try to close those gaps? And that might mean providing smartphones to folks. It might mean providing better broadband access and so on, but would love to hear from the other panelists and their thoughts.
Stephen, okay to jump in?
All right. Yeah, I saw you. I saw your mute come off. So.
Yeah, no, thanks. This is a common, a common question around, whenever technologies are developed that they might unevenly distribute. We have a saying at IHI that may be familiar to some of you: every system is perfectly designed to get the results it gets, right? And so when we think about any new technology, it doesn't matter whether it's a televisit or a new drug or diagnostic or whatever, right? Any new technology without intentional design will likely benefit those that already have power, access, privilege, etc. That's the way that technology development generally works. That means that if we want a different outcome, that we have to intentionally design for the different outcome. If we want a more evenly distributed benefit of the technology, if we want a more equitable benefit of the technologies or services that we're creating, we have to intentionally design from the beginning the deployment of that technology or that service or that new thing, whatever it might be in the future, so that we get equitable access to it in the future. So that I think applies as much for telehealth and telemedicine as it will for any other future new technology that will come on the horizon down the road, whether it's a booster, which it already is, or whether it is a new form of vaccination, or whether it is a new diagnostic or therapeutic service that will come in play, either for COVID or for any other new service down the road. So I think that it's just an important property that as we consider equity as part of our quality strategies and part of our organizational strategies, that we actually think about how we deploy technology and services across the board in a more equitable way in the future.
Thank you. I see
Yeah.
Nancy. Yeah.
Yeah, thank you. This is a great discussion, and I think we all agree that when applied evenly to the population, it can really be leveling. For many of our lower income individuals or people who work at certain types of jobs, even taking time away to come see a physician and or the care team can be a challenge for them. That unpaid time away from work to come visit the team means the difference between paying their rent or putting food on the table at times. The Southern California Kaiser Permanente Research and Evaluation Group did a study last year during the pandemic to assess the impact of telehealth on some of our most vulnerable communities. And what they found was very interesting, that across racial and ethnic groups that our Latinx patients had the largest increase, a 295% increase in the use of telehealth services. And when stratified by income levels, patients in the lowest income group had the largest increase in utilization of telehealth visits of more than 313%. So when available to individuals, people do take advantage of them. And we found that it can help close care gaps for some of our most vulnerable populations who otherwise would not be coming in to get the care and the services that they need. I think Karthik, both you and Kedar reference, as well as Nkem, wanting to ensure that we have availability, that we're not creating that digital divide among our communities. And so we have, as an organization, made some foundational contributions to organizations, safety net organizations, through Virtual Care Innovation Network. So nearly $2.5 million to help these groups expand virtual care access in vulnerable communities. So the money can be used in a variety of ways by these organizations to help purchase connecting devices, upgrade virtual care software, and audiovisual platforms to offer telehealth group therapy, for instance, to individuals who otherwise might not have access. So I think if we just look at what we can do as healthcare organizations and as systems, we'll find that there are opportunities in a lot of places.
Thank you, Nancy. I'm going to pivot us. So we got a question. It's sort of a data question. So Kedar, I'm going to direct it to you, and it's related to, and the IHA is kind of expert at this. Like, how do you pick measures that are actually going to drive the direction that we want to head? How do you change behavior with that? And I'm reflecting a little bit on the IHI's report here, and the top 5 sort of responses that they got for what does an organization need to do to advance health equity. And the first thing here on this report says integrate health equity into outcome measures, and there's some examples here. So I'm interested in your perspective on that.
Yeah, thanks. I mean, this is a tremendous challenge. I mean, it's very difficult to improve without good information on where the challenge lies. And when we started our work with delivery systems on the Pursuing Equity initiatives, we actually, this was one of the first things we did, right? All the systems were selected because they had made equity into a priority. And so we started to turn to the data, and data was a huge challenge, and it still is. And a large part of why it still is we don't reliably track gold standard self-identification of race, ethnicity, language, sexual orientation, or gender identity. We don't reliably track that information within delivery systems, within payers don't track that information necessarily reliably. And so we have a big challenge around this, and data being the lifeblood of improvement, it's critical for us to have a good understanding of inequities that are present in order to track progress and or in order to identify improvement goals. And because I think importantly, data is an incredibly powerful motivator, especially for clinicians. I know we've got a lot of clinicians on the line here, and it's a profoundly important motivator we have found in clinical practice. So in my practice environment, for example, until none of us thought we were treating our patients differently around how we were discharging patients with pain control medications, until we did the study internally in our department to understand what practice patterns look like. And in fact, there was a difference in how we were treating our patients across the 30 some odd hospitals in our group. So it is important for us to have that information, because once we have it, it's my sincere belief that clinicians have an intrinsic desire to improve, and nobody wants to be treating patients inequitably. And when the data shows us that we are, we can leverage that that motivation that's present in our foundational loads to create better practice. I do think that policymakers and payers can incentivize better data collection, and we're starting to see some work around this. Again, I've been mentioning throughout that I think policymakers are starting to think of, regulators are starting to create, articulate at an early stage now standard definitions around what should be collected from a data measurement perspective. And payers, I think, are going to start taking steps to not necessarily pay for better performance right at the outset or pay for closure of gaps in inequities, but actually paying providers to collect the data and to demonstrably show that they've collected race, ethnicity, language, and SOGI data that can be used then to understand whether or not there are inequities present in these systems. So I think that's sort of the short story, I think, on what we observed, but it is a massive challenge. It's the number one thing that we heard more often than not from providers in the poll around a big barrier to progress right now. But I think defining measures, standardization around how we define them, and then being supported by our payer groups to help us actually collect that data will make a big difference in sort of the availability of the information that we need in order to start to understand the inequities that are present in our systems today.
Nancy, you mentioned the role of like patient advisory councils. And one of the questions that arises is like, what's the best practice for setting up a patient advisory council? I mean, how do you get the appropriate representation, the diversity? And what does that level of engagement look like from your perspective? And then I'm sort of interested in Karthik, your national AMA kind of perspective. Are there best practices out there that other organizations or organizations like KP should be following? But let me turn it over to Nancy first.
Sure, it's a great question, Steve, and it's something that we have to be really, really conscientious of how the makeup of our patient advisory councils looks. In some regions, patient advisory councils are actually set up at each medical center through either the quality group or the community benefits group. There is a physician coordinator along with an administrative coordinator, and the council the council puts out calls to the physicians and to the staff to see if there are patients that they have in their world who would be beneficial to have their voice in these conversations. We're always looking for that diversity across race and ethnicity, age, orientation. I think part of the challenge, of course, is that if you have a group that meets, for instance, Monday through Friday during working hours, oftentimes the people who are most available to us are retirees or seniors. And so that there kind of narrows the diversity in terms of age, et cetera, that we can have. And moving it to a weekend, oftentimes people who have young families, for instance, they're off at soccer games or doing other activities or working. So it is something that it takes a lot of effort to try and make sure that you have the voices. And then it's up to each medical center to determine how they can best be used. But many medical centers use them in, for instance, member complaints. If there are themes of experiences in various care environments, for instance, bring that to the Patient Advisory Council. Communication, we used our Patient Advisory Councils members heavily during the pandemic. What message resonates with you? What's the best way to outreach into your community? And their voices really help to inform many of the approaches that we took.
And Karthik, is there anything like from your vantage point, because you get to see this from the point of view of multiple organizations, medical groups, what are they advocating for in terms of the patient voice? What does that look like? Who are they having to partner with to get the right people represented?
I think in this instance, I'm going to answer on behalf of myself and my personal experiences versus as a proxy of the AMA. Maybe the observation I have is that who we engage tends to reflect our biases. I mean, even in this conversation, and in most of the rooms I'm in, it's an echo chamber of privilege. And what I mean by that is, I bring a lot of privilege in my education and my role and in many ways, and I'm usually interacting with folks in the same way. And so we're kind of talking to each other, and it really begs the question of like, who's not in the room? Where are the poor folks? Where are the working class folks? So when we're trying to, for example, engage patients and communities, who can participate, to Nancy's point, it's the folks that have the time and the resources. And so we're not good at bringing in racial, ethnic diversity. We're even worse at bringing in socioeconomic diversity. So there's some things that we should just do at a foundational level. Pay them for their time, pay them for their effort and what they're bringing to the table. And that will by itself open up the door to bringing in more diverse folks from our communities who would otherwise not be able to afford to participate. So maybe I'll just make that observation and see if anyone else has anything to add.
I think just one other thing to add about this is, I'm just struck. I remember, the work that organization that we work with closely, South Central Foundation in Alaska, works with American Indian, Native Alaskan populations, and they can think about their relationship to the community in a pretty different way than we've observed other health systems necessarily relate to the community. And this may be, maybe different because of where they are or something along those lines, but they think of the community as owning the system, which is pretty fundamentally different than the way that most people, that most healthcare leaders that I meet think of the system. And I think that relationship of customer owner, which is the way that they talk about it in Alaska at South Central Foundation, is a very, very different way of relating to your community. Because if the community owns the system, then it's, you're obligated to find a way to make sure your owners have a role to play in the future of the system. And so, to Nancy's point about the fact that people may not be available to participate in the rooms that we've created for them, go to them. We're asking the question incorrectly. We should be asking ourselves, where does the community that owns us exist, and how do we get to them? It's a different way around, rather than inviting them to the tables that we've created and for their participation. So it's quite the other way around, and I think that might be a strategy that we can employ that would kind of turn the table a bit and really reshape our approach to engaging community to do the kind of equity work we're talking about here.
There's a really interesting question here, and Nkem, I'm gonna. This is a tough one. Okay, so I'll start with that. But so you're asking about infrastructure, and where we place our buildings, where we place our presence, how it looks and how it shows up, design, right? And Kaiser Permanente has actually, been thoughtful over the years about, how we engage a community or how we might actually, where we put a building. But can you talk a little bit about that, as an executive medical director, what that needs to look like, in the future?
Yeah, no, thank you very much. I mean, I think that's actually very important in the area where I am in Georgia. And as we are doing our capital strategy planning at this time, actually, we are looking at geo access, right? So one is how the building looks, but the first question is where you place them, right? So if you look at access to care, there are more hospitals, more healthcare facilities in the north of I-20 in the Metro Atlanta area, more than the south. So we're we're looking at that very seriously to make sure that as we locate our buildings, we are thinking about geographic access to care. So that our members have the right access to care and looking at underserved populations. So location is very important in terms of how they look. We have standard ways of constructing some of our medical office buildings, our Gen X buildings and things. So we are using the same across our geographic area, but maybe we need to also engage with the communities because again, we are looking at it from our perspective, what makes it easier and, for us to deliver care, from maybe there might be need to look at the input of our members in terms of how the buildings may look. But right now, we're actually trying to get the right buildings in the right locations to serve the members, especially the underserved members. So capital planning, location of buildings, access to care, not only primary care, but the specialty care access, we see some disparities in that in our own area. And we are trying to correct that to make sure we're not only the right buildings, but we'll have the right providers in those buildings to provide both primary and specialty access to care.
Yeah. And if I could add to that, Steve, it starts with that commitment to equity that we talked about at the very beginning of this conversation. In a couple of examples with our group and Kaiser Permanente, both in a remote area in a Hawaii region that services primarily Native Hawaiians, as well as one of the most socioeconomically challenged areas in Los Angeles, where our Baldwin Hills Crenshaw clinic went up. In both cases, the investment in the community sent such a powerful message to that community. And in the development in both cases of those medical office buildings, community leaders were invited into the conversation and asked the question, beyond healthcare, how else can this site, this structure, these facilities serve the community? From providing safe meeting places to locations for farmers market in often food desert areas to bring in fresh produce to communities and to serve really as a beacon of hope for the community that the world is investing in them to help to lift the care. And so it does take, however, that really focused commitment.
I'd love to jump in on this.
Oh yeah, please go ahead, Karthik.
Okay.
Please, absolutely.
And I think this ties in nicely to some of Kedar's earlier comments around metrics. So this is something I'm really interested in, and I know others are interested in as well, which is hospital segregation as it's manifesting today. And it's in the kind of framing of the Loan Institute, who we're partnering with in some work. It's a sort of tale of two cities. So what do I mean by that? It's a tale when you look at major cities of oftentimes an affluent academic medical center or a more affluent hospital, miles away from, for example, a safety net organization. And in the case of the former, they're not taking care of a fair share of their Black, Brown, Medicaid, other historically oppressed patients. So they're underrepresented in taking care of those patients compared to who they should be in their area. And then the safety net org is taking care of the vast majority of those patients and are oftentimes under-resourced in doing that. And none of that is accidental, right? Because this is all being shaped by financial incentives that the broader ecosystem that we're living in. So where we build our clinics, who we contract with, who we seek to attract, where we advertise, all of this is playing some role in who we end up serving, and also, interfacing with patient preferences. So part of it is that patients may want to go to a site where the staff look like them, where all the portraits on the walls aren't of primarily white men, where they get the services in terms of language or other things that they need. So how does this connect to metrics? So one of the worries that I have is this tendency to rush toward narrow downstream clinical metrics and the unintended consequences that can come from focusing too narrowly on that. So what do I mean by that? We could imagine, for example, the affluent AMC working on hemoglobin A1C for their Black and brown patients as like that's something that they're going to try to improve. And we could even imagine like layering on incentives for that, so that if you're doing better for your patients, you get incentivized. So this affluent AMC, which is serving a relatively small proportion of patients in that group and have more resources, can throw a lot of resources and look like they're doing well, while still systematically denying access to large swaths of the population. While the safety net org across the street, who's taking care of the majority of those patients and has less resources, is now struggling to do well on that metric and might look like they're doing worse. So I'm not saying we shouldn't focus on the downstream clinical metrics, but I think we need to balance it with the bigger picture of, can patients even get their foot in the door? Are we providing access to our communities in an equitable way? Are we referring them to services in an equitable way? So like transitions of care. And if we're doing that, if they can get in the door and we're in all aspects of our care, including specialty care, then are we delivering the high quality care and outcomes that we're looking for? So I just wanted to kind of point to that, because it's something I think we need to think about in healthcare, but also the regulatory and payer landscape as well. And Kedar, I'm especially curious if you have any add-ons or refinements in my thinking there.
So Karthik, actually we reached time, and with that was one of the most comprehensive answers, which could, really covers the gamut. And I really want to thank all of you for joining this panel. It's really been, I think, an incredibly insightful conversation. So thank you all for taking time out of your own busy days to participate in this webinar. And I want to thank everyone who tuned in, who may actually be taking the time to watch this later and watch the recording. So those of whom haven't joined us but will be joining us later. As we continue to deal with the implications of this pandemic, I do want to remind everyone that if you have not gotten vaccinated, please do so. That's our answer to how we're going to end the pandemic. It's also our gateway to how we're going to get back to being able to address all healthcare needs and do it in a way that has equity. Thank you all for your time.
Thank you.
Thank you.